Lumbar spine manipulation techniques. Lumbar roll manipulation. General setup. Position the patient in a side-lying posture with the affected side facing upwards. Ensure the head remains in a neutral alignment, supported by a pillow, with the spine straight and free of rotation. The lower leg, closest to the table, stays extended, while the top leg is flexed at the hip to 90 degrees, with the foot placed into the popliteal crease of the lower leg. The patient's arms should be crossed in front of their chest. The practitioner stands beside the table, facing the patient, assuming an asymmetrical stance, slightly angled toward the head of the table. Secure the patient's lower arm at the triceps and anchor the wrist against your own torso. Manipulative technique. With a slight squat, begin to rise while drawing the patient upwards and forward. You'll detect the correct segment once spinous rotation is minimal upon palpation. Use the flexor surface of your arm to apply contact over the patient's PSIS to induce lumbar rotation. Your other arm contacts the lateral rib cage and axilla region using the same flexor aspect. Instruct the patient to take a breath in and out. As they reach the end of exhalation, begin to engage the barrier by initiating pelvic rotation toward you and thoracic counter-rotation away from you. Apply the thrust once the barrier is fully engaged. Lumbar roll manipulation. T12 to L1 segment. Patient positioning and contact points. Ask the patient to slightly lift their top arm, enabling your dominant arm to slide between their torso and upper arm. Use your second and third fingers to palpate the lateral aspect of T12's spinous process with your dominant hand in a neutral resting posture. Your forearm should lie obliquely over the rib cage toward the axilla, gently drawing the shoulder posteriorly and assisting in segmental counter-rotation. The patient can gently press their arm down on your forearm for stabilization. Your supporting hand locates the spinous process of L1 using the same fingers angled toward the floor. Your forearm should rest on the iliac crest and gluteal region, keeping your elbow close to your ribs. Technique execution. Maintain a soft contact on both the rib and gluteal areas. Instruct the patient to inhale deeply. As they inhale, shift your center of mass, ideally your sternal notch, directly above the segment. At the end of exhalation, when muscle tension is minimized, deliver the manipulation. Important considerations. To improve patient comfort, a towel may be placed under the top arm. Avoid pressing down directly over the ribs or glutes as these areas are sensitive. Female practitioners should adjust positioning based on their naturally lower center of gravity, typically near the xiphoid process. Always synchronize the thrust with the patient's breathing pattern, applying the HVLA at the end of the exhalation for maximum relaxation and effectiveness. Lumbar roll manipulation. L2 to L5 S1 segments. Patient and practitioner positioning. Place the patient on their side, opposite to the direction of restricted rotation. Ensure their posture is straight, head neutral, lower leg extended, upper leg bent at the hip, and resting in the popliteal crease of the bottom knee. Arms should remain folded in front of the chest. The practitioner assumes a wide asymmetrical stance, 45 degrees to the patient, with slight torso rotation and leg contact with the table. Front leg is positioned toward the patient's head, back leg near the pelvis. Locate the specific target segment through palpation. Technique execution. Use the extensor side of your forearm to rotate the pelvis via the PSIS, providing broad, gentle contact. Your opposite forearm supports the rib and axillary region in the same extensor contact manner. Instruct the patient to inhale and exhale. At the end of exhalation, engage the joint barrier by combining pelvic and thoracic counter-rotation. Then apply the thrust. Modified lumbar roll manipulation. Key differences. The practitioner's contact varies from the standard technique, particularly in hand and arm positioning. The contact hand uses a pisiform, hypothenar, contact directly over the mammillary process of the lower vertebra on the restricted side. Fingers remain parallel to the patient's spine for correct alignment. The supporting hand secures the patient's upper forearm. Technique details. Preload the segment with tension using controlled positioning. Use the forearm contact to bring the patient's folded arms posteriorly and downward without pressing into the torso. Counter rotation is created by guiding the upper body backward while maintaining lower body engagement. The degree of hip flexion determines the location of lumbar tension. Greater flexion targets higher levels. Sense tension building by gently shifting the patient's knee with your thighs. Execution. Ask the patient to inhale. As they do, transfer your body weight over the patient, positioning your sternal notch above the target segment. Let your back foot lift slightly to allow the patient's knee to slide down, while maintaining knee contact to guide rotation. Finalize the manipulation only when the joint barrier is firmly established at the end of the exhalation cycle. Let me know if you need this adapted into a voiceover script, condensed for slides, or translated into another